Welcome to our Vatech monthly webinar series. Today is July 1st, 2020. I am Jim Mayer, Education Team Manager for Vatech America, coming to you live here in St. Louis. As always, I have the pleasure of working with my coworker, Paul Satone, broadcasting live out of Las Vegas. Welcome, Paul.
Thanks, Jim. Great to be back with you for another webinar. Today's session, we get to look at common findings in CBCT volumes with Dr. Dale Miles. Our last session with Dr. Miles focused heavily on anatomy and CBCT, so I'm really excited about this presentation today. So this will be our third session so far with Dr. Miles. And Jim, can you go ahead and share your screen?
Yes. All right. Now we're going. Perfect. So yes, Paul, we're bringing up Dr. Dale Miles today. Like you said, we've actually worked with him 3 times. The first session we had a couple months ago was about 2-dimensional panoramic images transitioning into the 3D or CBCT volumes, and what are we seeing in the comparison. The last session we did about a month ago was CBCT volumes and really heavily on anatomy, understanding what we're looking at. And today we're evolving that into, I guess, the third stage of that, which would be common dental findings. As we're going through these, what are some common dental findings? He's going to really go through that. This is all kind of a preview of what our clients have asked us for throughout the series and the feedback. And Paul, what do we have coming up in August?
So we're going to go ahead and continue our monthly webinar series on the first Wednesday of every month. Next month, August 5th, we have Sal Rodas from Sleep Architect presenting CBCT and sleep disorders. So Sal will be presenting, on disorders in dentistry, identifying patients for sleep disorders. Also, we'll be incorporating CBCT into that and easy 3DI software navigation. We'll discuss airway, sinus, paranasal sinus, and TMJ as it relates to the topics. So looking forward to that one also.
For sure. We also have started a new Friday series, basically a learning series specific for doctors and staff. So we did our first session back in June. It was the third Friday of the month. So the next one coming up is going to be July 17th. Paul, what's some feedback we got from the first session, and what are we doing for the next what we're calling it our Fast Track Friday series?
Yeah, so we did it last month. We had some great results, and we're going to continue it on the third Friday of every month to make it consistent. We're calling it Fast Track Fridays. It's going to be a series of 3 webinars. It's kind of designed, you can kind of jump in and jump out where you want. So the very first one, the first session, which is going to start at 8 a.m. Pacific and 11 Eastern, we're going to be discussing patient positioning, improving your 2D and 3D image quality. We'll kind of give tips and feedback, look at some good and some not so good images. We'll also take questions throughout the session. So it's designed to be a little more interactive, a smaller session there. So then after the first one, we'll take a 30-minute break. We'll come to the second session at 10 a.m. Pacific and 1 Eastern. We're going to call that one the Fast Track Beginner 3D Software Clinical Case Planning. So we'll look at multiple clinical topics during this session 2 here. And then again, taking a break, 30-minute break, and coming back for the final session in the series at 12 p.m. Pacific, 3 p.m. Eastern, Advanced 3DI Implant Planning. So we'll look at all the different tools and features of the Easy 3DI software as it relates to that topic. So that should be, it's going to be a good one.
For sure, and kind of a la carte sessions. If you want to have your staff listen or watch the positioning one, it's interactive, so more Q&A. Or if you want to have some new staff members or doctors go through the advanced implant planning, or even some basic case planning, going through endo, implants, airway, the basics to get us educated and build on the topics of the software, so everybody can be active in the office and utilizing the device for patient presentation also.
Yep.
Paul, all this really came about with everyone asking, hey, this is what we want to see, so we're trying to implement that for our clients. All that came through them communicating with us in different ways.
Right. So any feedback on any future topics that you would like to discuss or see covered, please feel free to email us at the sales email address on your screen. Anything for the education team, any software related questions, please email us at the education email address at Vatech America, or the CS for the customer support. Email is a great way to get a hold of support at the CS address. Of course, our website and our social media channels, all at the handle of Vatech America. So lots of ways to get in touch.
For sure. Looks like we have a lot of people who have been on past webinar sessions with us. We still are going to go through this, just the logistics of everything. The go-to webinar session, you can see Paul and I at the top of the screen. We're going to bring on Dr. Dale Miles here shortly. You'll be able to see his screen. We'll go through the presentation there. If you're having audio issues, click on the help button if you're using your onboard audio. Otherwise, go ahead and do a phone call in. Just do note that you will be on mute so that we don't have any interruptions to the presenter, but you can do a Q&A with the Vatech education team. And also what we're going to be doing is Dr. Miles may ask some questions. So this would throughout his presentation. So this will be the way to respond to Dr. Miles, or at the end of the session, we're going to set about 15-20 minutes aside for Q&A directly with Dr. Miles. We'll be answering your questions there on anything pertaining to his topic today or other topics, if you want to go that way. Paul, we are offering CE for this session.
Yeah, so we're doing the CE just a slightly different this time. So we're going to offer a CE credit at the end of the webinar. There's going to be a survey that pops up with a few questions. There'll be fields for your correct information as you want it to appear on the CE form, and then that will be emailed probably in a few days within the webinar.
Yeah, so we wanted to get that, so we make sure we have your proper title on the CE form is why we're asking for that survey at the very end on there.
Yeah. So today we're going to be discussing common findings in your CBCTs. Dr. Miles will discuss common findings in your scans. A lot's going to be covered in this presentation, as you can see there. So it's a pleasure to have him with us today.
Yes. With that, I would like to introduce Dr. Dale Miles. He is a diplomat of the American Board of Oral and Maxillofacial Radiology and the Board of Oral Medicine. He has held academic positions at several dental schools, including Connecticut, Indiana, Kentucky, Arizona, Texas. He was also a test construction consultant for the National Dental Examining Board for 7 years. Has authored over 130 scientific articles, 5 radiology textbooks, has given and been invited to presentations nationally and internationally. He has a website for teaching dentists and auxiliaries about combing imaging at drcombing.com. He's in full practice of oral and maxillofacial radiology in Fountain Hills, Arizona. And to date, he has read close to 28,000 scans. And with that, Dr. Miles, welcome. And let's get your
good introduction, guys. Yep, you got my screen up, I'm sure by now, huh?
Yes. So
yes. Can they still see me?
Yes, we can.
Okay, because I just put my screen up here. I didn't know if I'm supposed to go ahead and share it now. Show screen.
Yeah. So go ahead and do your share screen, and we'll.
All right.
Yeah. Let's see.
I'll make him the presenter. There we go.
All right. Perfect. So we can go ahead and see your screen, and welcome, Dr. Miles. Thank you. This is your third time with us today. In the series, we've been building on each one and getting really good feedback. And also, these are things that people can go back and review on the Vatech website. And we'll, at the end of the session, we'll talk about where to find these. If you did miss one or two of your first sessions there, we have them all recorded and accessible on our website there.
All righty. Well, thank you, gentlemen. You gave me the same introduction as last time, and I'll give the same joke. Someone asked me in one of these courses one time, how many uninvited presentations have you given? Anyway, not too many. I thought I'd share an emoji with everybody. This is what I look like with a mask on, although I get to practice from my home and my study or the hotel room or the airplane if I'm traveling. So I don't really wear a mask except when I'm out and can't social distance. Here's my older brother here up on the screen. They're giving a talk in Mexico. I hope there are some people that are returning to this webinar series that saw the first couple of things. This is going to be a much different one in that we're going to talk about some very common things that you see. I get these questions, as do the people from Vatech quite frequently. It always surprises me how much we forget after we leave our dental programs. And then when things pop up in our traditional imaging images or our CBCT volumes, we kind of forget what we were taught. So hopefully this will be a good refresher. For any Canadian colleagues out there, I am a Camerican. I'm a Canadian and an American. Here, became a citizen in 1999. So today is July 1st, which also happens to be Canada Day. So happy Canada Day, eh? All right, hope somebody laughed at that. So we got a lot to cover in the radiopacities. They're very common things, as you'll see in this list, with the exception of the osteoid osteoma, which we'll talk about briefly, but is an important finding. It's one that gets missed frequently and one that's very easy to diagnose, but you have to do something clinically. Radiolucencies, we're going to talk about plain old periodontal changes at the apex, periapical cemental dysplasia, and some other entities in that particular side of things. And one of these, the periapical cemental dysplasia, actually has several radiographic appearances. Some of you, if I don't know if there's any people as old as me out there listening in, but way back when we were being taught about these lesions, there was a term cementoma, and it was as opposed to true cementoma, and that terminology has dropped by the wayside. So the term for what you're going to see is periapical cemental dysplasia, and there are three different sort of radiographic variants of that we'll show you. So to start off with, there's a single periapical on the left-hand side of the screen. Hopefully you'll see my cursor. And you can see that there appears to be some widening of the periodontal ligament spaces on the lower central incisors. But over here on this, the patient's right lateral incisor, you can see a radiolucent area. If you didn't do vitality testing, if you didn't do percussion sensitivity, you might want to jump in there and do a root canal procedure, but you can kind of make out the periodontal ligament space around it within this lucent area. And this is an early stage of periapical cemental dysplasia. So certainly you would have to correlate this kind of finding with anything that you had seen on the radiograph or the cone beam, which we'll see later. This is just a scanned panoramic image on the right-hand side of a film-based image, and you can see a big ball-shaped radiopacity. Well, this could be any number of things in your differential, some exotic and some very common. So let's go through some of the common things. Periapical cemental dysplasia, as I said, has several stages. The first one I showed you was the early stage, and that's what it's termed, early stage periapical cemental dysplasia. The next image that you see on the left of the periapical flavor, the central incisor has a radiopacity surrounded by a large radiolucent rim. You sort of can make out most of the periodontal ligament space. This would be an intermediate stage lesion. And there isn't a lot of distinction sometimes between intermediate stage and mature. Mature is the last one. These probably would be both intermediate stage because you can see a ball-shaped opacity and a radiolucent kind of region around it. On cone beam CT, this is a reconstructed panoramic in an implant case, of course. You can see that there is a large radiopacity apical to the lateral incisor on the patient's right and a radiolucent rim around it. And when you go over to the patient's left mandibular region, just past the cuspid in the premolar region, you can see a similar entity. Well, if I saw, this is a thin slice reconstruction, so this is probably done at 5 or 10 millimeter thickness. If you wanted to see it more panoramic-like, of course, you could thicken it out. And you may see more lesions. When you see one of these, oftentimes there are multiple ones. So we did do some imaging, you'll see this one a little bit later on, to show that there were other quadrants involved. When you get your cone beam, machine and you're first starting to look, the first couple of times that you're looking at these images, this is normally the response. These images are great. What am I looking at? You know, because you have a whole different slew of anatomic sections to look at, and you can see 3 planes of section all at once on some of your interfaces for the machines. So you're going to question what you see. You'll have to, of course, maybe review this, maybe review some things in the textbook, go bird booking as I call it, and you'll come up with some of the entities we're about to discuss. This is a small field of view cone beam image. You can see that the arrow is pointing to a radiopacity. It's kind of ovoid. It's in an extraction site of a previous tooth. And most people would look at that and go, well, that's probably just a tooth fragment or a retained root portion. And it could be. But if we look at it in a thin slice format, you can see that it doesn't really look much tooth-like now. It kind of has a ball-shaped characteristic to it. I can't tell if it's joined to this cortical margin up here or not. But if we do some more imaging, and in this particular case, we did what I call a slab rendering. We thickened out the thickness of the slices and then applied a filter to it. We used a template for tooth and bone. And you can see that this actually is a small, dense object. It looks like it's got some type of union, or it's joined to the cortical boundary here. So this is probably an area of anostosis. If it did not have this little union to a cortical margin, basically it would just be called a dense bone island. And anostosis is just the kind of mirror image of exostosis. Exostoses grow outward, anastoses grow inward, but they normally come off a cortical margin. So if you see in an axial plane of section an image like this with a radiopacity and it doesn't look like it's joined to any cortical bone, it could be just a dense bone island. However, you would have to scroll through the slices. You would have to look at other planes of section to determine what it is. Most radiopacities are innocuous. Most have no clinical, ramifications whatsoever. On a very, very, very rare occasion, you can have an osteoblastic kind of metastatic lesion, but they're extremely rare. So most of your radiopacities in terms of dense bone islands, anostosis, idiopathic osteosclerosis is an older term for some of these. They don't have a clinical consequence, except perhaps maybe if you get it in an area where you're going to place an implant, it might become an impediment to your drill. This one we actually imaged in the cone beam format and did the filtration to thicken out the slices and used a templated kind of bone and soft tissue template to see that it was all by itself. It's a dense bone island in the middle of the posterior mandible. Below it, this radiolucent region is actually the inferior alveolar nerve canal to help orient you. And you can see here, as we went further back, that dense bone island might still be an area of anostosis because you can see a little union here, a little area where it looks like it could have formed off the cortical margin. So either way, neither need treatment, but it's just a terminology that you'll end up using. Anostosis if it's joined to the cortices, dense bone island, or idiopathic osteosclerosis if it's not. And this, of course, is the same case that I showed you just a couple minutes ago. So it's easier in cone beam to get to the truth when you do some type of 3D reconstruction, 3D imaging like you do on the clinical side of your practice. So this was anostosis. These are two separate slices in the same patient. In the left mandible, we see a round radiopacity sitting all by itself when we image this in other planes of section. This was a dense bone island. This radiopacity, quite a bit more floored, a little larger, kind of ovoid in shape, little lobulation to it. It looks like it did arise or originate from the cortical margin. So this is probably an area of anastosis. And of course, we can go in and look at other images that we can create in this cone beam imaging to see if that's true. So what we did is we did a reconstructed panoramic. You can see that this still on the bottom image in the panoramic reconstruction, you can see a ovoid radiopacity sort of close to the inferior alveolar nerve canal, looking like a dense bone island. But as you move up towards the towards the other images, we'll show you that one in a second. You'll see that the image on the right side of the screen, this is actually a dense bone island. It is all by itself sitting near a tooth root in the left posterior mandible. So let's go look at the other larger opacity and see if it is an island, a bone island, or whether or not it's an area of anastosis. As an aside, if you look up in the maxillary antra, you can see a large mucus retention cyst in the right and a smaller one in the left, a little less opaque. So dense bone island anastosis, and here's what it looked like when we imaged it. We showed it to you already in the previous image. We actually were able to show that the point of origin, or where it started from, was most likely the inner cortical margin of the mandible. So anastoses are also known as bone islands, so that kind of is where the confusion comes. A dense bone island should not be joined to the cortices in any portion of the imaging that you do, whereas an anastosis will be. They sometimes have a small focus or they are a small focus of compact bone within cancellous bone. And I thought this might be interesting for the people attending this webinar. In medicine, they have on some of their modalities lesions they call don't touch lesions or don't touch me lesions. And these are ones where there could be an incidental finding like anastosis, or they could be some other type of anomaly, but they don't need treatment. And if you went in and went to explore it, you might create more of a problem than actually exist with an asymptomatic patient. We'll show you another example of that in a second. Excuse me. That isn't COVID, I promise. That's just my froggy throat from being a little dry out here in Arizona. All right. So this is an axial slice midway through the sphenoid bone. The sphenoid bone I'm outlining here. I'll show you. I'll put some color in there in a second. But within the sphenoid bone, we have the pterygoid processes. Further south or lower down in the images, you would see the lateral and the medial and lateral pterygoid plates. But you can see a large radiolucent area in the patient's right pterygoid process, and that can be kind of alarming. It'd be, oh my God, is that some type of, simple bone cyst, traumatic bone cyst, some type of vascular lesion? What's going on? So here's the sphenoid bone. The area of interest, of course, is included within it. When we put it in another plane of section, you can see it still looks like a big old radiolucent lesion, but this is simply what we call incomplete pneumatization of the sphenoid bone. So that this is a normal anomaly. When you see it, if you did recognize it, if you were scrolling through and you went, oh my God, there's another one of those I don't knomas that Dr. Miles talked about in a previous session, you might be alarmed. You might get a second opinion from a radiologist or oral maxillofacial surgeon. Probably the radiologist would know, the surgeon may not. If you went to a neuroradiologist or medical radiologist, they'd be able to tell you what that was. That would be another don't touch me lesion. The access to that, the trying to get tissue to confirm by biopsy would cause probably more harm than the patient is experiencing. So there are some anomalies out there you should be aware of. Don't touch me lesions. Here's one. This is actually a dense bone island in the vertebral body. This is a little bit further down in the spinal column. No one would go after this. The orthopedic specialist or the neuroradiologist would say, no, that's a dense bone island, don't worry about it. In the mandible, looking quite similar, but again, joined to the cortex is a radiopaque area, and that is an area now that you know as anastosis. This is what it looked like, the same case from the coronal point of view, and you can see the point of origin right here with this inostosis growing inward from the cortices as opposed to outward in as mandibular torus would look like. So those are just a few of the things that you'll see. It'll raise some concern, but you don't need to do anything about them. Of course, the beauty about CBCT imaging is that you can put it in several planes of section, and you can see this is an axial view, a coronal view, and a reconstructed panoramic view. If you saw the pan by itself, the panoramic reconstruction, you might be concerned this was, cementoma or semenoblastoma or some type of lesion on the tooth itself. But in actual fact, in the other planes of section, it proves to be anostosis and needs no treatment. As opposed to that, this particular radiopacity in the right posterior mandible is all by itself. You might have an argument for it starting off the inner cortical margin here into the cancellous bone, but it really looks like it's freestanding. So this I would probably call a dense bone island, again, needing no treatment. To confuse things, and I also used the term earlier, idiopathic osteosclerosis, I looked at this case and saw kind of a conical shaped radiopacity, and I thought, oh, is that a impacted tooth that is undergoing ankylosis or resorption? I couldn't really tell what it was. You could make an argument it's coming off the outer cortex of this maxillary bone, but in my language, I'd probably write this up as idiopathic osteosclerosis. Okay, so we see a lot of different opacities. None of them should surprise you now. We're going to move into that a little bit more. We're actually going to kind of flesh out periapical segmental dysplasia from those other opacities, and then also lesions like focal and florid osseous dysplasia. But before we do, I thought I'd show you an interesting case. Nothing in this image looks like it could be a salivary stone, and that's because this is a thin slice, relatively thin. This is at about probably 4 or 5 millimeter thickness. We were looking at the lesion on this particular molar, the periapical lesion. Within this image, a lot of interesting things were going on. There was a branch of the inferior alveolar nerve, an accessory canal for the IAN that goes up to the external oblique ridge, that kind of variant. And there was also a big radiolucent area. And it wasn't the mental foramen, it just was too big and not quite anterior enough. So we did some imaging on this case as well. We did one of these transparent kind of holographic images, and you can see that the lucency stayed, and lo and behold, we picked up an opacity, and it looks like it's just distal to the distal root of the lower right second molar. However, when we did the actual 3D imaging of that region, it became very clear that on the axial plane of section, you can see there's a big old salivary stone or sialolith. And in the sagittal view, in this particular reconstruction, you can see the stone itself. And we pick up now this radiolucent region that's engaging the cortex of the inner portion of the mandible. So what we really have here is we have what we call a Staffney defect, or a better term for that is a lingual developmental submandibular salivary gland depression, a big long mouthful. I'll show you another case in a second. But the beauty, again, and I think I talked about this in the first two courses, is that I always try and do the best and most explicit imaging I can for the client. I put this into the 3D reconstruction mode, which is very simple to do in the third-party software. I get cases from every manufacturer, every machine, so I have a different software, a third-party software that allows me to do all of these particular images. And most of this can be also can be done in the Easy 3D Dental, so you need to ask your reps about that, their software package as well. But there's the stone, a large submandibular salivary gland stone, and it's probably at the hilum. The gland is sitting here and the duct's coming up and running along the floor. and most likely this is right at the hilum of the gland. And you can see this isn't sticking out. This is actually a defect going into the bone. This is the Staphy's defect, or lingual developmental submandibular salivary gland depression. We'll see another one a little bit later on. Putting this in, thickening it out and adding one of the preset templates, you can see that we can show the stone, I can show the canal, and when I went a little bit further forward, or came further forward, we can actually see the salivary gland defect as well. The Japanese researchers, early on radiology researchers, many years ago, did psilography on a lot of these lesions and found branches of the submandibular salivary gland architecture ductal system going into this region. So we did now know the origin of these defects. They're not Staphy defects, they're salivary gland depressions. A little departure from those radiopacities is the osteoid osteoma. The jaws are very uncommon place for them, but when they do occur, there's a very simple thing you can do to differentiate them from, from some of the other opacities that we're showing you. The patient will have pain, and it'll be described as a dull ache. And if you ask the patient, well, did you take anything for it? And they say, yeah, I just took a couple aspirin. A non-steroidal analgesic like that will take the pain away completely. And so then you have the diagnosis. It's kind of like tooth pain, but you won't find any tooth-like findings. You won't find any pulpal change, periapical change, or periodontal things to basically start you down that path for a diagnosis. But if they have dull achy pain in one of the lesions I'm about to show you, you have to consider osteoid osteoma. Now, these aren't in the jaws, obviously, but I want to show you something that holds up across no matter where the lesion is located. You can see within this bone, this is a long bone, you can see a radiolucency with little punctate, they call them opacities within them. So little areas of mineralization. Here's another one in the distal humerus. Sometimes they will actually resorb or remodel the cortical bone around them, but they have this kind of appearance of opacity and radiolucency. This is one that came off the internet, and I put the actual URL in there for you so you could go and look at it. But I want you to look closely. This is a normal panoramic digital flavor. You can see that there's some orthodontics going on. They're keeping spaces maintained for lateral incisors that are missing congenitally. But I don't see a lesion at all in the panoramic. And when you look at that, you go, oh, the patient's having dull, achy pain. They've taken some type of analgesic and it went away. Well, look where that is hiding. It's hiding down here on the lingual side of a molar. And I believe it's actually this first molar on the lower right. And you can see that no 2D imaging is going to pick up this lesion. So if you don't have cone beam, if all you have is a periapical and a panoramic, you either should possibly send this patient to a friend who has a cone beam or a laboratory service, or consider getting a machine yourself so that you can do some of this more advanced imaging and make more significant diagnoses. So as I told you, the most frequently reported symptom of an osteoid osteoma is a dull and boring pain, a bone pain type feeling. And this basically worsens at night. I don't know why, possibly it's postural related, but if you've got dull and boring pain and there's no dentally obvious cause, then you could even ask the patient, say, well, I'd like you to take, when you feel this pain come on, take a couple of just plain old aspirin, and if it disappears, we may have a diagnosis and we'll go looking for it. So here's the case that I saw relatively recently, a 30-year-old white female. She described the pain as deep in my jaw and achy to the clinician who sent it in to me. And this is the reconstructed image from the cone beam. This is probably at a 25 or 30 millimeter thickness. You can see a root canal procedure, maybe a little leaking of the coronal portion here under the crown, root canal procedure done. And that was the area that we thought, well, we'll focus on that, see if there's any missed canals or any other problems. But as soon as we went to the axial view, you can see a radiolucency with some punctate mineralization or punctate radiopacities within it. And that patient's pain, when we requested that the doc try her on plain old aspirin, went away. So you can see that we could actually see the origin of this patient's pain. And I don't know whether or not the root canal was done just because that's where the patient pointed, and the actual lesion was not related to pulp death at all, but happened to be this rare lesion called an osteoid osteoma. So if you look at, this is a plain image on an older, off the internet, an older plain image showing that mineralization shows up much nicer on the cone beam imaging. So we tried to find it in other planes of section. You see we got a little bit of it. This is towards the tongue side or the lingual side, and you start to pick it up. You can see almost like a ghost image of the molar. And when you look here, you can see a pretty distinct image of that lesion. And then in 3D reconstruction, you can see, I'm sorry, it was on the buccal aspect of this tooth. So cone beam can help you out with difficult diagnoses. The description, small ovoid mixed radiolucent radiopaque lesion between the apices. Where did that description come from? Well, that came from my report. This is a typical report with the findings of sinuses, nasal cavity, airway, cervical spine, and osseous, TMJ, dental, and other. And you can see that most of the findings were in the dental section. My impression clinically was that that it was suggestive from the radiographic description of an osteoid osteoma. And I even sometimes say if they're experiencing pain alleviated by simple analgesics, this is a likely diagnosis, and normally put a citation in at the end. There were other rare lesions that you could consider, but given the fact that this lady, when I called the doc and he tried the aspirin, that it went away, it was most likely osteoid osteoma. It will be cured by removal, so it would have to be surgerized. So aspirin can cure a lot of things. Give it a try sometimes. So we're moving on. Periapical segmental dysplasia. I told you the early stage is radiolucent. The mixed stage is a radiopaque central region with a large radiolucent rim. Normally you'll see the PDL intact. By all means, you have to do vitality testing, sensitivity, electrical testing. You have to do it all first. And if there's no reason for that to be there from a dental disease point of view, then periapical segmental dysplasia is the most likely diagnosis. You can see a couple of more mature lesions over here on the right. And all it does is the radiopaque material within there, the segmental type or like material, just keeps forming. They're pretty well self-limiting. I guess you could include those in don't touch me lesions as well. If you went in to try and get those at a biopsy, you probably devitalize all the tooth, and then you would be doing root canals. So vitality tests are normal, and look for an intact PDL. This is a cone beam example. You can see tooth 28, or for our international folks, this is the lower left first premolar. Okay, and you can see the radiopaque area with a radiolucent rim, and it actually has another radiopaque margin around that, but this is a mature stage lesion of PCD. So that's why I've included in the opacities, and you can see the three different appearances in the different planes of section: coronal, axial, and in here a reconstructed panoramic view. So mature stage PCD. I have seen cases where there's been several lesions at different stages, of course, in the jaws. This is actually all one lesion. This is a little bit lower, higher up. Sorry, this is a little bit more inferior on the right, a little bit higher up on the left, and you can see there's opacities within a radiolucency. This is not the root end. This is another mass of material within the lesion. They sometimes resorb. That was real easy for me to get to. I just, click and pull a tool out and actually look, and you can see that it was starting to erode the inner surface of the mandible near the genial tubercle. So They can do that. Again, they still don't need treatment. And I took away some of the, I did some image enhancement to take away some of the bone to see what I could see inside, and you can see some part of the root and then some of this opaque material around it. It's primarily solid. You can see the PDL still around a portion of the tooth root. These are thin sections and then slab renderings, but this is a mature stage lesion of PCD, periapical cemental dysplasia. And you can see it got a little bit larger, sort of more superiorly, so that these can get fairly large, but as they get bigger and they're focal, we start to give them different names, and we'll move to that in just a second. So I think it's a continuum. I think you have early, intermediate, and mature stage lesions of periapical cemental dysplasia. When they get quite a bit larger and may not be near or adjacent to or overlapping the root structure, but just in the local region, we call that small f focal osseous dysplasia. And if you have multiple radiopacities that are all over or in multiple quadrants, we call that florid osseous dysplasia. And florid osseous dysplasia has other things in the differential. I only have one or two cases I'll show you at the end, and we'll talk about the distinction and why you need to know why the other entities are in that differential. So if you look at this particular case, these are just different sections of the same lesion. You can see this is a thinner slice over here, thicker slice on this side. It looks periapical, but there's absolutely nothing going on in the dentition. There are no carious lesions. The periodontal bone situation is quite normal, but you can see a large, well-defined radiolucent / radiopaque lesion in the posterior mandible associated with the apex, the mesial apex of tooth number 19 or 3-6. And if you look at this, you can see some other foci, opacities. Maybe you could even describe them as punctate on this side. But this is a focal osseous dysplasia. Again, looking weird, looking wonderful. You're probably thinking odontogenic, but don't rule out some of these more common lesions. I see this focal osseous dysplasia quite a bit. And I see these are frequently referred by the endodontic community to me because they're real good at radiolucent lesions and dental disease that cause from pulp death, but when they see an opacity, they kind of freak out. Okay, so what am I looking at? All right. Here are the 3D reconstruction, or 3 planes of section rather, and a 3D reconstruction over here. You can see that there was maybe a little sort of remodeling of the outer cortex of the bone, and I thought maybe I was seeing that in the, as kind of an expansion over here on the buccal aspect in the 3D. But really, this is a don't touch me lesion. Again, you wouldn't do anything with this. Do your vitality testing, pulp testing, and all the other tests, and look for dental disease first. When you've ruled it out, then you've got an entity that just requires watching periodically radiographically. And you can see I tried to show maybe it was starting to cause a small cortical perforation, and that might be what this represents here, although this is in a good location for the mental foramen too. So this is probably foramen, and this is probably the early remodeling or resorption that's occurring on the buccal aspect of this lesion. So focal osseous dysplasia, and you'll see it written in the literature as small FOD as opposed to florid, which is large FOD. Let's move to that. When you have florid, of course, means that it's either large or there are multiple areas of it. Well, here we go. If you look at the right posterior mandible, you can see sort of a mixed lesion in the molar region. We come over here to the cuspid area, and you can see a large radiolucent area. It even looks like it's possibly spreading these teeth apart. You can see another mixed lesion over here with a big radiolucent rim. You can see another lesion over the bicuspid in the left maxilla. And who knows, this might be another lesion on the apex or associated with the apex of this molar. but there's been some root canal done, and quite possibly they didn't recognize that there were other lesions that it could be. Even the lateral incisor looks like it's got something occurring at the apex. So this is probably a florid osseous dysplasia just at an earlier stage. It hasn't gotten so florid that all of these areas are quite radiopaic. Same type of case, you can see a large, this is almost looks expansile and kind of is, but there's multiple areas of opacity within this radiolucency. None of the multilocular lesions do that except perhaps the Gorlin cyst, and it doesn't have that much opacity within it, just 1 or 2 flecks, possibly a Pinborg tumor. But this ended up being all teeth vital, no problems with the dentition. This was what I would call a florid osseous dysplasia, and one of the regions was the anterior mandible. We also had lesions in the anterior maxilla. We also had lesions in the bicuspid region, both maxilla and mandible. So it looks really awful. It looks like, oh my God, this patient's got something that they're, going to have chemotherapy and radiate. No, this is basically florid osseous dysplasia with lesions at different stages. And that's why I think of these things as a continuum from periapical segmental dysplasia and the different appearances it can have through focal and onto florid. Even when something is called florid osseous dysplasia, we might be catching it at an earlier stage where the osseous change, these are just plain old fibroosseous lesions, the osseous change might be occurring slowly and the expansion as well. So don't panic when you see these, just get a second opinion. This is the reconstructed pan from this case. Now it's looking much more, quote, florid, where you see these big radiopaic areas. So again, you just need to watch this. The other entities that would be considered when you see something this large, and again, you can't consider this common. The florid osseous dysplasia is not rare, but it's not common. But things like Gardner syndrome, things like Paget's disease, those are much rarer. Paget's could be included here. Gardner's could not. Gardner's normally have extra osseous radiopacities, and I'll show you that in a second. I'll show you that now. You can see that some of these big radiopacities are outside of the mandible. They're not falling within the mandible itself. There's a lot of tooth problem because of lack of eruption and displacement of things, but this is more likely a Gardner syndrome, and Gardner's has a whole list of things that goes along with it, but the most important is these patients have intestinal polyposis that is has a propensity to transform into malignancy in the colon. So if you saw this, yes, you do worry. If you saw this, just get a second opinion and don't worry too much. Paget's, I'm not going to go through Paget's disease of bone. You will have to review a bird book for that and determine all the different things that happen with a patient with Paget's. I've been teaching and looking at radiographs for over the 40 plus years now, and I've seen one case of Paget's. So it's quite uncommon, and they're going to see their physicians first. Gardner's similarly. So growths in the colon, the intestinal polyposis that basically can undergo malignant transformation. They do get hyperdontia or development of extra teeth. They can have other tumors besides in the dental bases like skull and other bones. And I don't know what the cysts are under the skin, but probably some type of sub or epidermal cysts. And this is just reminding you that the colon is the important part in Gardner syndrome. So again, not common, but again, in the spectrum of the radiopacities, that would be at the far end. Hopefully you don't see any of those cases. This is the saguaro flower on the saguaro cactus, the happy cactus that always has one arm up saying hello. We had big fires out here in Arizona, and we have very beautiful but tragic, sad pictures of a lot of burnt saguaro, and each cactus takes 150 years to grow the first arm. So it'll be 200 or 300 years before the cactus grow back in that area. The undergrowth and other vegetation will. But we'll move on to radiolucencies. I have to go relatively quickly. That's because, you know, Paul and James always take the first 10 or 15 minutes of a 1-hour talk. So that's why we're going to go to 1:15. But let's start in. Apical periodontitis, a generic term for the changes that occur at the apex of a tooth when as a sequela of pulp death. You know, pulp dies, you get abscess, which you don't really see much radiographic change, then onto a granuloma, which you do, and then onto a cyst if it's the body's trying to wall it off and forming a cortical margin around it. So we're going to deal with the radiolucent one, the apical periodontitis, and add in early stage PCD, which I showed you already. A fibrous healing defect, which you may or may not have may or may not remember, also called a surgical healing defect, and we see quite a few of those post endodontic treatment. However, these days, if endodontics fails, most times instead of doing an apicoectomy and retrograde restoration, people just proceed to extraction and implant, which I think is probably a better clinical choice anyway. The Staffney defect, again, we'll show you that in a variant of that. Fibrous healing defect or surgical scar. I put it in twice just to remind myself of surgical scar. And then we're going to talk briefly about the differential diagnosis for a floating tooth, because if you see a single tooth with absolutely no bone around it in the absence of periodontal bone problems, you have a very significant differential diagnosis, and that tooth must be surgically removed and all tissues submitted, or the eventual diagnosis is going to come back to harm you, okay? So when we say apical periodontitis, we're talking about some type of alteration of the bone pattern, the cancellous bone at the apex of a tooth from pulp death or trauma and then pulp death. This would probably be granuloma, although histologically you can't tell until you get some of this tissue, whether it's abscess going to granuloma, granuloma going to cyst. Cyst would have some type of margin on it, but still could have granulomatous tissue. So it's really a catch-all term for any one of these histologic lesions that could occur at the apex of a tooth from pulp death. When it has a cortical margin, it changes things. There's no way to get any medications in there. All of the things that are happening within the central portion of the cystic lesion, your body's cells for defense can't get in there to actually solve things or heal things. So this is why root canal is done and attempted first, but if you see a cortical margin, it's unlikely it's ever going to resolve completely. Some people say, well, you can go out, you know, the apex and stimulate the area to bleed and it'll cause inflammatory change and disappear. I don't believe that. I did enough endodontics myself to know that until more recently and some other better modes of treatment came along, this was going to get an apicoectomy and retrograde restoration, hopefully enough crown root ratio to restore the tooth. So if I see a margin like this in this day and age, it's going to be, I can try the root canal, Mrs. Jones, but it's probably not going to resolve. You have very little tooth structure here. I can, you know, do this. You can spend a lot of money on a root canal, a post and core and crown, and get whatever years we get out of it, or we can take that tooth out and do an implant. So the treatment is explained to the patient. It's their decision to make, but you can give them lots of good options these days. Granulation cholesterol crests down these in this central lumen. You can see some inflammatory cells around the margin. This is a cystic margin. So apical periodontitis is any one of those three lesions. You'd have to see the tissue histologically in order to make a diagnosis. When you see a thickened hyperostotic margin, no matter if it's around the end of a tooth or it's in a sinus area or somewhere else, I call this hyperostosis. Should be termed hyperostosis. It means this has been a long-standing problem. The chances of this resolving are highly unlikely. You'll never get back to normal health because this is dense bone now being laid down, try to wall off this infection. But this would respond to root canal procedure if done properly, of course. And you have to separate that from the metal frame, which sometimes can be a problem. So the stages of periapical segmental dysplasia, the one you're looking at is probably the more mature stage like this that I showed you earlier for a radiopaque lesion. Here is the radiolucent variant of, I think, periapical segmental dysplasia in this case. I'm not sure about this one, although you can have more than one tooth involved, of course. These are the mental foramina. So you would want to image this if you saw this on a pen or a periapical and do cone beam to try and help yourself out. You can see that that was done. These are thin slices, and this is a early stage lesion of periapical segmental dysplasia. They too can cause some remodeling of the cortices, but the pulp will be vital. That no tooth related disease. I would watch this radiographically. There would be cases that I've seen in the past where if they first saw these 3 lesions, they went in and did the root canals that were unnecessary. The fibrous healing defect, I took this one out of the Journal of Endodontics, and you can see that root canal procedures have been done, but possibly they went in to clean that area out again, and what they've got left is a surgical scar. I don't know which of these is, but I do know that I've seen cases. So here's a successful apical and retrograde amalgam. And this is a different case, but this, when I see it, to me, that's a fibrous healing defect because the lateral's missing. So I'm going, oh, they probably had root canal retrograde, the thing failed. The scar is from going in and doing the apicoectomy, and it heals in from the edges. You can see the bone coming in towards, from the periphery towards the central region, but because it was a through and through defect from the buccal to the palatal, it never fills in completely. So you have a surgical healing defect or fibrous healing defect, and it would just need watching radiographically to make sure that it wasn't something else. But to me, that's a classic. So fibrous healing defect or surgical scar. I see these quite a bit. Our root canal procedures, apicos, are still done quite routinely. This particular case, there was a procedure done in the maxilla, another one done in the mandible. When we looked at the one in the mandible, it was really easy to tell that the cortex was totally destroyed. The root looks flattened. There's a root filling material from the other end, okay, from the apical end. So there's going to be a defect there at some point. And this is what we saw with the 3D reconstruction. Again, that probably won't fill in completely. So you have to watch it radiographically to make sure nothing additional is going on. The floating tooth, a term some of you have heard, I'm sure. Some of you when I lecture, and I've got 200 or 300 people in the audience, about a third have heard it, and they're usually the ones that graduated within the last 15 years or so, because we didn't introduce this term till probably a couple decades ago. And what it was describing a tooth where you'd see a tooth with absolutely no bone support. You look in the other areas of the mouth for, periodontal bone changes, and there are none. If there are none, this is a scary looking tooth then, because, there could be plain old periodontal bone loss, but the differential includes significant other things, such as lymphoma, Langerhans cell granuloma, metastatic lesion, or any of the sarcomas. So to give you that differential, this floating tooth, the first thing you want to think commonly, it could just be plain old periodontal bone loss, and you'd have to check other regions of the mouth. All right. If you check the other regions and they don't look like that, the jaws are good locations for metastatic disease, tumors from lung and cervix and prostate and whatever. They can go through the Batson's plexus, valvulus plexus of veins in the back and get up to the jaw bones. And the differential, as I told you, is number one, think commonly. advanced localized periodontal bone loss. Number 2, Langerhans cell disease. For older clinicians out there, that was the old histiocytosis X group, and there was a whole bunch of names in that too, like Letter Siwi and Hans-Schuler Christian. No, they identified the cell type. Now it's just called Langerhans cell disease or Langerhans disease. You can also consider lymphoma, not an uncommon appearance for lymphoma, metastatic disease, as I said, or rule out any of the sarcomas, osteofibro or chondrosarcoma. So that should have said chondrosarcoma. That is a scary differential when you think of it. And that differential, when I'm looking at it, as soon as I add any one of these other disease entities, that's got to go to the pathologist for histologic diagnosis. You don't just take it out, scoop out the granulation tissue or what you think is granulation tissue and throw it in the bucket, because this is where something will grow out of the socket within 2 to 3 weeks, and then the lawsuit follows several months later after all the chemotherapy and radiation. So if you see a floating tooth, and if you look at this dentition, there is some minor periodontal bone loss, maybe a couple millimeters here and there, but this particular tooth, this lower right first bicuspid, has a large radiolucent lesion. Doesn't quite look floating to me, but again, this is a reconstructed pan, so we got to look at it more precisely. When we look at it more precisely in the axial view, you can see quite a significant lesion around this apex, and you can see that the bone has been destroyed towards the tongue side. On the lingual, this tooth does look like it's floating in a sea of something. This one would have to be submitted for histologic diagnosis. When we did the 3D reconstruction, I breathed a little bit better sigh of relief, because I did start to see that some of the architecture and some of the other areas for bone were suggestive of periodontal bone loss rather than this. And it could be. I've had patients in the past that they had some inflammatory tissue there. They said, yeah, I dig at that area with a toothpick or whatever, and I always fish stuff out, and they actually can create a granuloma or some type of reactive lesion by playing with it. But this one turned out to be plain old periodontal bone loss, thank goodness for the patient. But that one was removed and sent for histologic evaluation. The 3D really told most of the story. So even though I included it in my sort of notes in my differential and suggested they send it for evaluation, when I did the 3D reconstruction on this case, you can see that there was more bone loss than was suggested by the panoramic. So you have to learn to live in color. You have to learn to basically look at all your cases and use all your tools to help you make the diagnosis. The final thing I'll talk about is this Staphny bone cyst or defect, the lingual submandibular salivary gland depression. It normally in the past was described as a ovoid, round to ovoid radiolucency, which occurred in the angle of the mandible below the inferior alveolar canal. However, we find them in several places. You can see this is not below the canal, it's mostly above the canal. There's also an anterior variant, I don't show it here, but these can occur anywhere salivary gland tissue can impinge upon the bone. And so you have a salivary gland defect here. How would we image it? Well, we go in and we do the thin slice. This is sagittal view. You can see kind of looks alarming in that particular view. We go in and do the 3D color reconstruction. This is the outside of that area. This is the inside of that area. This looks nasty. It looks like a big metastatic lesion, but it's not. If you were to do scintigraphy or nuclear medicine, it still would come out as a hot spot, and it would scare people because they'd think, oh my God, there's something really nasty going on there. But it's just change from tissues that are resorbing that bone that reside in the submandibular salivary gland. So here are the different appearances. This is kind of classic, this axial view on the bottom left, and then if you have 3D to confirm it, your suspicions are confirmed, and you can call it a Staphny defect or a submandibular salivary gland depression. And again, watch it radiographically. So the cyst has been referred to by many names, and I'm going to give you them all. Static bone cavity, static bone cyst, latent bone cyst, a Staffney bone defect. It's 1 to 2% in various studies, but really it's just a lingual subinhibit or salivary gland depression. And normally I said it was located between the inferior alveolar canal and the inferior border. That's the most common location. However, we can have other regions, and I want to show you one. This was a case that came to me that this was the incidental finding, and then we actually found a meningioma in this case at the very edge of the exam, and I actually think I showed it to you in a previous study. But the oral surgeon was concerned about the arthritic changes he thought he saw in the condyle, and then this big lucent defect in the neck of the condyle. And you can see the first image that I did had a radiolucent area here. There was another radiolucent area here. I'm now thinking well-defined punched out radiolucencies, this has got to be multiple myeloma. It was not. We did the 3D reconstruction. It's not so much it's punched out, it's a salivary gland defect. This is where the parotid lies. The parotid lies in the outside here, but wraps around the back of the mandible. And so this is a variant of a salivary gland depression happen to come from the parotid. So I don't want you to be intimidated. I want you to just get educated. I'm going to throw in 1 or 2 little things here for diagnostic dilemmas and hopefully end up with a vertical root fracture for you. So root fractures, bone quality for implants. If you've got questions, you can ask me about that. Radiolucent areas around implants. I've actually mentioned to my colleagues at Vatech that maybe we should do a whole, they're doing an implant session for you, but maybe we can talk about some of the strange things that happen and some of the failures for implants at a later date. Root fractures can occur anywhere. They can involve the root even from a cuspal fracture. You can see all kinds of them, vertical split tooth. You can find them sometimes, but the fracture has to be smaller than the pixel, okay, or rather the pixel has to be smaller than the fracture in order to see them detailed. So horizontal, vertical, and oblique. Horizontal, pretty easy to find. Vertical are the tough ones. Oblique are probably the most common. So let's see. This is from the internet, from the Spears Education Center, and what they were looking for. They were looking for, well, there might be a fracture if you see a lucent area adjacent to the tooth. Well, that's what 2D imaging can show you, and I guess there are a whole raft of classifications. Tamsi et al. Did a classification. You can read this later. They had all kinds of things that were related to a possible or the diagnosis of a vertical fracture. So if you want to look it up, I put the journal sort of citation in there for you. But I'm going to show you some cases. This case, there was a post, very nicely done. The root canal looks like it was finished quite well. You can see a radiolucency beside the tooth and an area of probably dense bone island or anastosis above it. As we were going through the case, I did see what I thought was a horizontal fracture within the near the apical third of the end of this tooth, and of course that would be just about where the post would terminate. So that's a good place for fracture if it's weakened. And when we looked at it in several different planes of section, we were looking to see if this was anastosis or dense bone island. This was the view that I saw, and I went, oh, that's fractured. That's why this is radiolucent. It's not failed root canal. It's a fracture of the tooth and, you know, problems post-operatively. So we did some more imaging. You can see that through the coronal section, there's a horizontal fracture here as well. I did some 3D color rendering, which wasn't real pretty, but it did show the fracture through the tooth in the exact region that we see it on the thin slice grayscale view. Case 2, similar case, although this one is more of a vertical or oblique fracture. Excuse me. Persistent lesion, apical periodontitis on tooth 15 or tooth number 27. When we looked at it in different planes of section, lo and behold, we get to the coronal view, and you can see an oblique fracture through the palatal root, which is not visible when you're doing 2D imaging, putting a receptor here and coming in this way. We wanted to make sure that they did see it, so we went in and looked at other areas. There's the apical lesion, there's the fracture. We did some more fracture, and then, I'm sorry, that's the same image I showed you previously. I had another one where we showed just a panoramic alone that actually showed the fracture in thin slice. Apologize for that. And then just today, I reported a case that I received yesterday, and I left the date in for you. This was 6/30/2020, and this was someone who was apparently, quote, diagnosed by a medical intuitive, and some of you know that term. And they were looking for, quote, cavitations. Well, this gentleman had a lot more going on than cavitations. A lot of his pain and problems could be explained by plain old dental disease. Huge periodontal bone loss defects, vertical defect between the lower 2 molars. All of these defects went to the apical region of the teeth. Not only that, in this particular case, you can see that there's an interruption in the floor of the sinus. So the periapical lesion on tooth 14, this is the root end, actually communicates with the adjacent antral space. So they have an AO defect. You wouldn't have seen it on a panoramic. Here is the reconstructed pan. This is an image intensification type. You can see the rounded edges where the distortion occurs. But here's the lesion on the tooth. Here's the vertical defect. You might get a suggestion of a fracture there, but not real plain. But when we did the thin slice, you can see the fracture right here. And then I went in and looked for it, and you can see it through near the coronal portion of this tooth, then going down the middle of the tooth and extending down through the tooth. So this was a large enough fracture, probably because the tooth was bone support was weakened sufficiently that when they bit on it in some fashion that they caused a fracturing of that portion. And this is, even though it's ugly, this is a enlarged and reconstructed thin slice panoramic view to show the fracture portion of this particular tooth. So to show you something pretty, here's my backyard. I want to thank you. We'll open it up for discussion. James, maybe you could bring the group back in. I did finish at 1:15, and we can go a little bit longer for questions if you like.
Perfect. Thank you, Doctor. Yes, thank you for your presentation. We do have a few questions, and I believe Paul, there he is. Paul, what questions do we have that have come up throughout the presentation?
Paul, you're muted.
I'm still muted there, Paul.
Sorry about that. Sorry. Okay, the first one. What would a FOD look like on a 2D pan?
Actually, and are you talking, when you say FOD, do you mean small FOD or large FOD?
It doesn't specify.
It doesn't specify. Small FOD on a pan would look very similar to some of the ones I showed in thin slice, a mixed radiopaque, radiolucent lesion, but kind of focal, kind of near an apex, maybe even overlapping on the apex. And you would see it on a 2D pan, it just wouldn't be as distinct necessarily. Great. On the FOD, the big FOD, what you would see are, either florid opacities in several quadrants or mixed radiolucent radiopaque lesions or any combination of those. So we're looking at a still image, a movie frame out of a larger movie, when it happens. So it's really difficult to make diagnoses without seeing and knowing and understanding the disease process that's going on over the different period of time. Follow-up exams are always appropriate in those cases to see, what happens to those lesions. Do they change? How do they change? And do they cause any signs or symptoms?
Got it. Another question. Somebody just asked, Joseph, is cortical expansion a common feature of FOD?
Let's just say it's not uncommon. I know that sounds like a political waffle and hedge, okay? But I've seen them that don't cause expansion, and I've seen them that do cause expansion. So expansion is a disturbing feature radiographically when you see it, but if you put it in the overall context of what is the rest of the lesion appearance? What is there any dental disease? Okay, and if there's no dental disease, then basically you're probably dealing with something very benign. The odontogenic cysts and tumors, of which there is a myriad of those, they have other signs, symptoms, other attributes that lead you to believe, well, this isn't, this is an odontogenic problem. This isn't just something from the bone and cementum. So, that's a whole other series of lectures on that.
Got it. Okay, next question.
Yep.
How do you differentiate PCD from FOD on the views?
Well, I kind of thought I covered that. Periapical cemental dysplasia, again, because it has this spectrum from sort of largely radiolucent to a mixture of radiopaque with a large radiolucent rim, but an intact PDL, to a more mature stage where most of it's radiopaque. It's really not, those are the three kind of stages, and you have to understand all of them. But again, clinically, do the vitality testing, percussion sensitivity, and make sure that there's no disease before you think about, calling it periapical cemental dysplasia. But that's very common. PCD is quite common.
Okay, another question here, also from Joseph. Do any radiopacities cause numbness of the inferior alveolar nerve?
Alveolar?
Alveolar, sorry.
Okay. Sounds like you fly planes or something. Alveolar. Okay. Anyway, not really. Pose that question again, because there was something else in there that I was going to address, and I forgot it by being cute there.
Do any radiopacities cause numbness of the inferior alveolar nerve?
I mean, the reason this is hard to answer is because, what do you mean by radiopacity? There could be things impinging on the canal, but again, in 3D reconstructed and multiplanar views in cone beam, you would be able to see that. I mean, I can even see an implant that has actually been pressed into the canal area. Are you with me? So if I can see that on cone beam, examining a radiopaque lesion, we'll call it, that you think is causing pain by impinging or numbness by impinging, you'd want to make sure that it actually impinged on the nerve. So you'd have to image it in all the different planes of section and do slab and other procedures to it to see if it actually did impinge, okay? But certainly, I think I mentioned it earlier, there, on a rare occasion, we do get a metastatic lesion that can be radiopaque rather than the typical destructive radiolucent, ill-defined kind of lesion. So I'm hedging a bit because I don't want to say yes, I don't want to say no. I think you just have to do your diagnostic evaluation and workup and do the best imaging you can, get a second opinion when it's necessary in order to determine, is that lesion you think you found really causing the patient's numbness? Okay. You can even have central lesions of cranial nerves that cause peripheral manifestations. Are you with me? The nerves that supply the trigeminal nerve is three of these. It's got the ophthalmic division, the maxillary mandibular. Well, that's the terminus of the nerve. The numbness could be from something in your brain that actually is affecting one of the branches as it courses back through and goes to the cranial area. So that's a loaded question, Joseph, when you ask that one. So.
Okay. Next question. What is David asked? What is the risk of placing implants next to or through FOD?
I don't know if there's any risk unless that FOD is close to the inferior alveolar nerve. Okay, it's especially in the mandible. But the other risk is that I don't know how solid, if you have a region of focal osseous dysplasia and it's quite dense, it may impede your drill. You may not be able to go through it like you can cancellous bone. So it might deflect, it might, that would be a risk, of course. I'd look to select a different site possibly, or maybe that's a patient to consider for pre-prosthetic surgery. We do it for lots of other instances. Maybe you want to say, okay, look, Mrs. Jones, Mr. Smith, we've got to get that removed. We'll have a histologic diagnosis then, and then we can place your implant after healing or do an immediate graft or whatever you're going to do. But it's going to be a clinical decision at the time that you're evaluating the patient. So I can't predict what's going to happen if you try and drill through it.
Okay, one more question. One of your views showed bifid IDN. How often do you see proper separation or even separate 2 or more smaller ID canals?
Yeah, it's not as uncommon as people think. I see the branches in the surgery literature actually, they actually cite 2 different types, 2 different locations that they go in a relatively routine fashion. It also explains why every once in a while we miss a block when we think there shouldn't have been any problem. But I don't advocate taking a cone beam just to look for the accessory canals. If you did have a problem with a patient that didn't get anesthesia in an appropriate time frame, you might consider CBCT to look for the accessory, but I wouldn't do it as a routine thing thinking, oh, that I got to know if it's there or not. I'll give you one clinical tip, and this comes from, goes so far back I almost hate to share it, but it held up for me every dental procedure I ever did that involved a block. I also struggled, like many of you, where you've got the thumb and forefinger and you place it right over the occlusal plane and try and find the inferior alveolar nerve where it comes into the mental foramen or the mandibular foramen. And you say, oh yeah, I'll put 1/3 of my or 2/3 of my anesthetic there, then I'll withdraw and do another 1/3 for the lingual. And then you wait and you wait. And it's like, well, I must have been high, and I just wait a little longer, and you wait. Oh, maybe I was low, I better go back in. I had an oral surgeon teach me one time, and he said, I don't know why they don't teach you this in dental school. You got a whole carpule of anesthesia. He said, I find the spot where I think it is, I inject 1/3, I withdraw a little bit, I go up, I inject 1/3, I withdraw a little bit, I go down and inject 1/3. I never miss. And I went, why didn't they teach us that in dental school? They still don't teach that in dental school, okay? So you don't ever have to miss a block unless there's that accessory canal. If you put in 3 different locations, you don't have to sit and wait for anesthesia.
Okay, last question here. Somebody's asking in the chat where your images are from in the presentation.
All my cases, okay, except for the ones that I qualified by saying these I took off the internet. So again, I've had up to, oh geez, sorry, my answering machine I can't shut off, so I can't even mute it. My wife just did though from another room. So, okay, where did I get the images? I put it in a third-party software. It's called On Demand 3D. And I basically get all my cases from different clinicians referring them in. I can't own everybody's software. I can't own Easy 3D Dental and Anatomage or whatever the other packages are. I've played with most of them, but I get the cases from dentists and I image them in a third-party software that is quite robust, just like Easy 3DI.
Great.
Perfect.
All right.
Thank you.
You're welcome. I know I went over time. I apologize, but I want to thank everybody for letting me hopefully educate them again. And they'll go back and review. They'll understand a little bit better. All right.
For sure, Dr. No, thank you. You were right on time, and we appreciate the information. We had a lot of good questions and a lot of good feedback coming in. Couple things we wanted to talk with you about specifically, we've talked in the first two sessions, but you do have your Scanatomy app for doctors and staff to learn more anatomy, going through the 3D slices and 3D volumes as an educational tool. And then also visit Easy Writer, excuse me, for CT reporting and kind of guiding our doctors through some reporting and kind of two different things of products of yours that you're closely work with to review for our attendees to kind of review and look at on there. So we appreciate those tools. Thank you again for working with us. You always have so much valuable knowledge. Everything that we did today, this has been recorded, so our doctors will go back or have the capability of going back and reviewing. Again, Dr. Miles, thank you so much. Paul and I are going to talk a little bit more about what we have coming up, and then also where we can find this recorded session on our website. So,
okay, thanks, guys.
Gotcha. Thank you again. Thank you for your time.
Okay.
All right. Well, thank you everyone for joining today. Paul, we do have August 5th, like we talked about before. Sal Rodas from Sleep Architects is going to be going over CBCT and sleep disorders. That's coming up August 5th. We also have our Fast Track Fridays for our staff and doctors, so we'd really like you to look into that. That all can be found on our website. For recordings of the Vatech webinar today, or really just information about your device or any devices we have, you can go over to 3D imaging for the specific device you have, 2D image or intraoral, user videos for the staff and doctors, software if you have questions on the 3DI software, 3D Plus, EasyDent Eye software, or our recorded webinars. So if you were able to join today but want to go back and look at some of the two previous sessions with Dr. Miles, please go ahead and review that webinar session tab. Everyone's going to get an email after this that's going to include these links to this to the software there.
And that's all under the service and support area of the website if you go to the homepage.
Correct. And then also service and support for when you have an issue or have a question. First place we like to point our doctors is to our service and support tab. We have an FAQ section that goes through downloading software for upgrades. What do I sanitize my device with? Other commonly asked questions to be able to get that done really quick for you and your team. Lastly, July 1st today, the CE credit. When you close out, you'll get a survey. Also, we'll follow up in the email survey. Please take time to fill out your name and your title and how you would like it to appear on the CE form, and we will get those out to you within the next week or two. And we thank you everyone for your time. We look forward to meeting again August 5th and hopefully August 17th for our Fast Track Fridays if you would like to have your staff and doctors join us there. Paul, thanks again for a great session, and thank you all from the Vatech family. Have a great
thank you.
Technology Day and Happy Canada Day. Thank you.
Thank you.